It seems like we have a dozen people, so I might just get it started, I think. So, good morning, good afternoon, good evening, wherever you are, and happy Friday. Welcome to another session of the Extracorporeal Hour. I'm Cedric Dufayet. I'm the lead of the Extracorporeal program for UCDF in San Diego, and my co-host is Jethro Forbes from Cornell University.
Hey folks, good to be with you this morning. Across the globe, we get folks from all over, which is awesome. As Cedric said, I'm Jethro. I'm up at Cornell University running our program here in extracorporeal therapies. And as always, every 2 weeks we come together in this session where it's open, free to learn, and in a judgment-free zone, if you will. I've been doing this a little while. Cedric's been doing a ton of this, and I know a lot of the names I see on the screen here have a wealth of experience, and some folks are newer. And one of the goals when Cedric and I kind of recreated, the vision philosophy for this was any question was a good question, no matter how fundamental it seemed or how advanced it seemed. We'd work through it all together and learn something in the process. So welcome you all to that. And would love to hear from you guys and hear a little bit either about your program, if nobody has a case, or more excitingly about a case or a challenge or a complication or something that's come up for you guys. So with that, maybe we'll open the floor here.
Oh, we have quite a doozy right now.
Oh, Brooke, tell us about it.
Nice.
Um, so 14-year-old female spayed. I think it's a Shih Tzu mix. Uh, Acute AKI. She spent 3 to 4 weeks going in and out of urgent cares and facilities for uh pretty severe abdominal pain and like a low-grade fever and coughing. And she got diagnostic several times, didn't really find much. She had opiate pain injections and going home on gabapentin, that kind of thing, and everything was just not really improving until, of course, she had blood work several times, and it was actually fine within those weeks. And then all of a sudden, she crashed and burned, of course, and represented to the same clinic she had been going to, and her butane and creatinine, too high to read, that kind of thing. And she was laterally recumbent, and she actually presented because she was having first-time seizures. And then she kept seizing through um, typical seizure medications, both IV and oral, uh, at that clinic, and was hospitalized. They placed a UCath, noticed she was pretty much anuric, um, and transferred her over here. Did not look good at all. But one thing they did find is a couple of things. One, they found a nodule, like a lung nodule. And then the other one, or some torse, they had a mass effect in the chest. And then as she was in and out those few weeks, um, she did have some submandibular swelling on the left side. And she actually went home several times through that, waiting for an oncology appointment, because they thought it was a lymph node and wanted to get a sample of that. And she was waiting for that. And then by the time she presented crash and seizing, that other clinic found that that was actually acute uremia. Uh, and it was very, very, very swollen, swollen enough to where her airway was swollen, everything was swollen. The cuterebra was ruptured, and they removed it, but she had the halo sign on her gallbladder, probably some anaphylaxis along with it. And then when they transferred to us, we were actually very concerned that of larval migration, both chest and potentially brain, after seizing through all of these seizure meds. And um, we wanted to get her on emergency dialysis right away. And of course, finances were discussed quite a bit. And um, I kind of, we were going back and forth. I was hoping they literally the hang up with their finances at some point. They were like, "Oh, this is only two treatments. We want to be able to afford a minimum of the three." And I thought, well, that's if you live until three. Um, Plus, I was like, I talked to, I mean, neurology through their exam, they thought it was localizing to something brain rather than systemic. Um, and of course, even from the day before, I had seen their BUN creatinine, and I was like, that's not that bad. Could be worse. And the nephrologist is like, "Are you out of your mind?" And just, I hadn't seen our blood work from that we did when it presented. Holy smokes. Um, so well up in it was above 350 on the BUN, and the creatinine was 12. Um, and, but everybody was very focused, and especially after the neuro consult on this. And I was like, can't we, like, why don't we just run her through MRI? And then maybe we can save doing an emergency first dialysis if her brain is Swiss cheese. Um, but of course, nobody wanted to give her anything sedative or, of course, anesthetic because of the kidney injury. And then there's the contrast. So then I said, well, can't we, if we don't find anything, can't we pull the contrast out uh, on the dialysis machine? So we were kind of Googling that for the most part. And at first, they were like, no way. And then later on, people were kind of like, maybe. Um, so, and I know they mentioned it to the owner. So, um, and then also I said, well, this dog isn't going to take much to MRI it. And even if it is anesthesia, her respiratory rate and effort was so terrible. We needed to intubate her even for sedation just to place the dialysis catheter, and we were going to put an E-tube in. And I said, well, we have to give her some drugs in order to do that, to do the dialysis. So shouldn't that, if we're already taking that hit, maybe we can do MRI. But of course, it was 4:30 p.m. uh, by the time I was able to bring that up. So that they went over and asked imaging, and they're like, absolutely not. And even the anesthesiologist was like, hell no. I was like, all right, fine. Um, but uh, so we gave her some fentanyl bolus and just some propofol to do the procedure, to place the catheter. Um, my coworker placed dialysis catheter while I worked on a PICC line from her mangled legs, and to try to get everything done at the same time. Uh, we were worried about all the swelling from that acute uremia to be able to put an E-tube in, but we were actually able to go below that. It was very submandibular, so we were able to go below that and still get an E-tube in. And I'm sorry, my stories are long-winded. Um, just tell me if
They're they're great. No, it's perfect.
I'm
We're gonna have lots of follow-up questions, I'm
uh,
sure. Is this
um,
maybe this is an okay time for folks to just check in and ask questions if
yeah, sure.
and I think, I mean, you have brought up, I think, in the crux of this, and there's a lot of different parts to this, like two really cool subjects, and one is the use of contrast in an existing AKI, and whether we across the board know that we're going to make things worse. Is it actually going to get to the kidneys if there's not flow there, for one? For two, I think the evidence, and this is an interesting discussion, and maybe for another session, even the evidence of use of um, contrast material in dogs causing an AKI versus in people, and the concern there maybe a little bit disparate. So I think there's, a discussion to be had there. And then the other one that you brought up is exactly that, kind of the battle, if you will, the collegial battle in the patient's best interest of sedation slash anesthesia versus their AKI and their electrolyte imbalance, and whether or not they're stable otherwise. So I think that's another really solid discussion that we could have amongst our group to provide each other with some of the language and some of the maybe the evidence and the anecdotal, experience that we all have, because you nailed it on the head there. Well, we have to sedate and anesthetize this dog to get the dialysis catheter, and maybe not with very much. But we have a little bit of a slightly, I don't know, maybe higher comfort level with sedating these guys when, the more pristine anesthesiology folks may want things a little more perfect. And we know we have to try and get that catheter in so we can try and optimize what their electrolyte
Oh,
now.
yeah. And of course, the potassium was like 8.5. We brought it down to 6.2 medically, with medications beforehand. But I still even, well, I ended up being wrong anyway. It was uremic encephalopathy. Uh, so that would have been for not probably. But I still think, I went to anesthesia. I followed their protocol for the induction and all that on the dog. For just our catheter, I still think, why can't you do TIVA through the MRI? I don't know, whatever. But it's a good thing it's a good thing it was a no, I guess, because I saved them from that. But that dog stopped. Um, she not only so I mean, I think she was in status. She had never, since she presented the day before at the other place, stopped facial twitching. The generalized seizures were gone, but she never stopped facial twitching, and she had a very strange sort of lateral, sort of rotary nystagmus going on. And all of that completely resolved within the first 90 minutes of the first dialysis treatment, and never came back. Um, Now having her seize through all of those seizure medications, I thought for sure um, that she was just going to keep on seizing and that it must be brain, and I don't think it was. Um, it was a nightmare. She had no stridor or stridor, but very acidotic, breathing, a bit heavy. But I had a beast of a time trying to intubate that dog. It it looked like a completely swollen up bulldog, and somebody had to take a Q-tip and like pull up the soft palate for me to even try to see the airway. And I was having a terrible time trying to get her intubated. Her airway was so swollen. And so we were worried we weren't going to be able to extubate her, um, or, that she would have to at least recover on high flow or something. Um, but we, funny thing, after 90 minutes of treatment, she also started to wake up a little bit from her sedation, and because we left the tube in, of course, and she actually started to extubate herself, which is fine. So we took it out, and all of the sudden, the second we extubated her, all the alarms went off. The catheter would not flow. Uh, and um, and we went to investigate it, and there were gigantic clots all up in the catheter. And I mean, she had been getting, now they're all like blending together, but she was not in a good spot. She had that typical mixed coagulopathy going on. And we were expecting, we're like, oh, she's probably going to be really sensitive to heparin. Her ACT, we started out at like 146 or something, and we went for a conservative bolus and CRI, and everything was flowing great. No issues whatsoever until she got extubated. And then there were giant clots in the catheter, in the lines, and she clotted off the entire circuit. We started with the Prisma, because she was so azotemic. Um, so we had an HF20, and she clotted off that whole thing. We had to completely change the set in the middle of the treatment. And yeah, she was very, very clotty. She's gotten 4 treatments now, but we've had to guide wire change out every single catheter. for the treatments. She's not produced any more than 1 ml per kg per hour of urine the whole time. And every time she rebounds higher. And because her kidneys, we kept saying, oh, once she's stable, then we can do CT and MRI for her brain, her chest, and everything else. She's had chronic hypoglycemia. We were considering some sort of sepsis somewhere, but uh, early in her hospitalization, someone sent out also an insulin glucose ratio, which was very abnormal. Um, but, and then she's now developed, after her treatment, uh, I think it was Wednesday, um, we took a look and that cuterebra spot was 3, 4 times the size of it was when she came in, and it was hard, tons of cellulitis. And then it had a center that was really just about to rupture. And then all this cellulitis and swelling had moved down to her ventral neck. And we had put a probe on it. It looked solid, submandibular, the ventral neck all the way down there looked maybe fluidy, but it actually ended up, it was almost all cellulitis. We ran out of the room and snagged the first surgeon we saw and had him lance it for us. There was a little bit of caseous material, but it's mostly all just cellulitis. And she's got massive peripheral edema. Her legs are painful. And now all her PICC line got infected around the skin there. We had to change that out. The E-tube looks great. And the catheter site itself, we thought we saw pus, but we're wondering if it was from other infections around that, especially the cuterebra site. So that is so swollen now. We have no option to put the catheter on the other side. And now they think she has cable syndrome. Yesterday, we were infusing her catheter with TPA, and we did a TPA lock. The day before, when we were having issues, we went ahead and gave sodium bicarbonate a go. I mean, it didn't do anything, but it didn't. I was trying to push that, especially when Carolyn was talking about it a year or two ago, because I thought it was very interesting. And my coworkers were teasing me. They're like, your sodium bicarb didn't do anything. I'm like, shut up. The dog's clotted anyway. Um, but we put a TPA lock in it last night. So we ultrasounded her neck yesterday, and she's got a gigantic clot in the right jugular extending into her right atrium. And so they think some of that is cable syndrome now. The dog's been up and down clinically. There's a couple times already where she's been standing up, barking, wagging her tail, but then she goes back to being kind of recumbent. And definitely, they said maybe some of these things are paraneoplastic. Maybe some of them are like we did an FNA of the lung nodule, and it was just necrotic. She had an echo, which was normal because we had found a chest mass. It looked like it was heart-based, but it was actually just thoracic, right at the heart base. And then we've got that insulin glucose ratio. I mean, some people think maybe she's got cancer everywhere. We're not sure. But I mean, I feel like we've only scratched the surface barely of this dog's problems, and we're not really ahead on the kidneys either. And it's been almost a week. And so now it's getting to be one of those cases where everybody's like, are we seriously still doing this? At first, honestly, even the fact that she survived the very first treatment to the next day and looked so good the next day, I was insanely happy and impressed. But now it's getting to be like, I don't think this is gonna go well. So they're teetering on whether or not we treat with dialysis again today. I don't think I haven't heard anything that anyone decided, but they're worried that we'll lose any kind of flow through that right side, and you definitely can't put anything in that left. They're like, so yesterday the criticalist was like, well, if we lose the right, we lose the dog. But I mean, I kind of think we're on that route anyway.
And so what are the you say you're not ahead on the kidney point of view. What are like her post-treatment values? And I think you mentioned she's rebounding even higher than she was before. So where are the post-treatment and the pre-treatment for the next one right now?
Let me take a peek. The I've been just kind of, since I wasn't here every day with her, I've been sporadically um taking a look at values and being like, oh, those aren't that bad. But I didn't look at the trends. They said, no, 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 she's rebounding higher each time. I was like, okay, fair enough. Let me pull her chart up. Oh my goodness. Why is this coming? Uh-oh.
Cedric, maybe while she's looking for the data, I'd make two quick comments. I'm in the car, so I hope I'm audible. One is the facial twitching. That's a real common presentation in animals that have moderate to severe uremia. So I wasn't really surprised when you mentioned that it resolved, and so that's kind of a characteristic feature of really severe acute or chronic uremia. The other comment related to Jethro's discussion about, what do we do about contrast procedures in animals that are uremic or could predispose to an AKI. If you need to do those procedures, carbon hemoperfusion will remove all of that. In fact, that was the original indication for the hematologic device, was to remove contrast during cardiovascular procedures, where the cardiologists often give massive amounts of contrast, but at least carbon will remove all of that. So if that's something that needs to be done or would be benefited to be done in the patient, you can, and the animal's going to be put on an extracorporeal circuit, you can remove all of that contrast with carbon.
And do you think, would you
So I
be,
remember in my logic, like the initial indication was removal of contrast. I think though it was iodinated contrast agent more for CT scan. I don't remember they had any data on gadolinium.
For MRI.
Yeah.
Yeah, that's what they were going back and forth on. And we just kind of Googled what they do with humans, because I can't imagine that humans need all that imaging. And it just said something about that they'll give those contrasts as long as it's within 24 hours of their dialysis treatment.
So I actually just found a case report from 2024 in the Journal of Vet Emergency and Critical Care that was published by Dan Gordon and Kathy. So I guess it was when Dan was at Ohio at the time, where they did intermittent hemodialysis for removal of gadolinium in a dog with severe kidney disease. And they did get like a really significant reduction in the levels with the pre-treatment serum concentration at 26.3 milligrams per liter down to 0.9. So definitely it looks like intermittent hemodialysis could be efficient at removing the gadolinium. I mean, I never had any experience with that, but at least we get that case report from Dan. I don't know if he's on the call today.
well, and I think the message behind this, and I think you and Kelgo both kind of said, like, if you need the information to make an important therapeutic, or maybe even in this case, if the brain was, filled with neoplasia, is this an end of life decision. I think there may be some, balancing of the risk versus not, and if carbon would help with some of those potential risks, choosing, one of the, at least with the iodinated, and so I guess this isn't the GAD that we were talking about for MRI. So, but perhaps, if depending on the structures you're looking at, perhaps a CT would give you the information that you needed over an MRI to choose a contrast agent that would be removed a little more efficiently. Um, so it's kind of about making some logical choices in that if the information is going to change what you're doing. And to Brooke's point, I mean, in this one, the dog got better after a day, or at least improved neurologically, to the point where it was stable enough, or progressing in its stability. So that was good, and that kind of proved that maybe the need for the MRI wasn't there. I wonder, um, Dr. Hokamp, I don't know, or Cedric, you guys, the notion of contrast associated kidney injury in our cat and dog species. Dr. Hokamp, do you see it, kind of on the pathology side of things? Are you still on there? She was there a second ago.
I am here. Are you able to hear me?
Yeah, yeah. Is this something that you guys come across, on the pathology side?
I don't remember a case recently of where we've actually truly been able to confirm that that was going on. I do remember a while back, and unfortunately, I don't remember all the details, where it was suspected. And when I was at OSU, one of our criticalists wanted, I think they had a project planned to investigate this in some of their patients receiving contrast. And unfortunately, they left OSU before that ever got off the ground. So I haven't seen it very often. The typical thing that I see is when the student workers come to me and say, why is the USG like 1.128? This makes no sense. I keep diluting it. And I tell them, go find out if it's on contrast. And then, sure enough. And we just didn't have it in history. But I haven't seen these very often, no. I'll message Dr. Nabity and ask her.
And what I can gather on the human side, rates of incidents are, at 3 to 13% or so. And may depend on the type of contrast used. The earlier generations, the higher osmolality is what seems to be the risk factor, or the inducing part of the injury. But there's a little bit of a widespread, and again, this is anecdotal among some human nephrologists that I enjoy their podcasting efforts. There is some skepticism there as far as it legitimately being, how high of a danger it is, and it's got to be there. Of course, it's there. But as I can see, it seems to be a little bit of a diagnosis by exclusion. If you see a rise in creatinine, there's not another cause for it after a contrast study.
Yeah,
I think
that's basically the same kind of conception I've had with it.
I think there's been kind of a shift on the human side where they actually semantically they shifted from contrast-induced nephropathy to contrast-associated nephropathy, because the causation was not evident, and it seems like with newer contrast agent, it seems like the risk is pretty low, and a lot of time if they're looking into it, they actually find another cause potentially for the acute kidney injury, to the point where I think there's actually kind of two camps on the human side, like some nephrologists thinking that it's actually not a thing, and some others saying like, yes, there's still like some effects on the kidney, and we cannot exclude that it's causing some degree of acute kidney injury, but it's
I've
definitely
never
not
been
cut and dry.
I've never been terribly afraid of contrast, iodinated contrast agents in my career. But on the human side, with cardiovascular procedures, where they give a lot of contrast, about 20% of those patients end up with some form of AKI. So I think it pretty much depends on how much you give and what agents you're using. But I don't recall it being a big issue in dogs.
Yeah, I think to kind of combine Cedric and Dr. Cowgill's point there, I think in those cardiac procedures, they see a ton of contrast and there's that high rate of AKI. There's a ton of other potential, reasons for that AKI in terms of perfusion as well as my understanding of those, which is why the cardiac procedure associated AKI models are so, widespread out there. It is interesting, and I think there's frequently in my shop as well. There's discussion of this animal has a mild CKD and but has some need for contrast, and weighing the pros and cons, and if it does change my clinical approach. I've our radiology folks are they've got that brick wall up for sure, and our internists are sensitive to it as well. But it's a conversation that we have, and sometimes we fall on the same side of the coin, and sometimes I'm overruled, and we find other ways, without contrast to try and be safe or protect them, whether the risk is real or not. But I think it falls under there is no necessarily black and white answer, obvious answer, I think, from what I'm gathering from the rest of you guys. Erica, do you guys run into this at Penn as well? The discussion around whether or not contrast is safe to use?
Yeah, I mean, this always comes up, but I agree with what has been discussed. I think my approach is usually if they need the contrast, we do it to diagnose what's going on. So, and I agree. I've just followed some of the human nephrologists, and it seems like there is some debate about is it truly causing an AKI or not.
I think most of us probably all follow the same folks, so we're probably all washed over with the Kidney Boy and Joel Top and all that group.
Yeah, he's the best.
It's just listening to again a little bit off track here. They just put out the most recent Channel Your Enthusiasm episode looking at hypoosmolar states.
Yeah, it looks like post treatments we've been getting creatinines um, between 1.9 and 2.6 post treatments, of course, and BUNs are getting pretty low, anywhere from 11 to 50 on some of these. And then um, next mornings, we've got BUNs that rebound to anywhere between like 100 and 120 kind of, and creatinines from 4 to 4.7 is in general. Yeah, and still definitely no, her urine production's not great, and it really goes up and down. It'll go anywhere from 1 randomly to then 0.3 mils per kg per hour, and it's kind of all over. Really, I
And
think of it, hey, at least that's one tube that hasn't gotten infected yet.
there you go. And
And
Brooke,
it's like pre-treatment the next day, or is she on a
We did 2 days in a row, took a day off. Um, we might have she took the whole weekend off. Oh yeah, she kept filling up with massive amounts of pleural effusion, which the cytology doesn't show anything there. She's got mild peritoneal and pericardial effusion. But yeah, they went ahead and did her again on Monday, and then I believe we skipped Tuesday. We did Wednesday, and now we're, I guess, still talking about the possibility of today. We skipped yesterday.
and Brooke, where's I know you've exchanged your catheters a couple times. Do you have a sense of where the ports are? Are they in the cranial cava, caudal cava, heart?
Yeah, I guess I'm no radiologist. To me, the last exchange on the X-ray to me looks like smack in the ventricle almost. But every time I ask radiology about that when I'm worried, they're like, well, those views don't really prove that. It still could be in the almost to the caudal cava. I was like, all right. So I don't know. It's pretty if it really followed the cava line there, it's like almost to where the caudal cava would start on the X-ray right after the heart.
I mean, Cedric or anybody else, for that matter, to climb, a BUN of 11 up to 100, 120 just overnight, that seems like a pretty substantial jump from a generation standpoint. And I wonder if there's maybe some access recirculation. Our posts are measured
Mm.
maybe.
And sometimes that's more 48 hours when we skip a day. It seems to be pretty consistent. I think only probably we only did 2 days in a row once where it rebounded that high, but I don't think we're pretty surprised with how high she started.
It might be just be in a hypercatabolic state too.
Yeah.
Uh, and also I feel like the smaller dogs sometimes actually have a higher neurogeneration than bigger dogs. More so, they often like start with a higher BUN compared to the creatinine than larger patient, and they tend to escalate higher and faster as well. So that might be one of the reason. Just to go back on the X-ray, because I feel like I have that debate with radiologists kind of like pretty frequently, where
Mhm.
when we have a catheter that is a little long into the atrium, and they just like call it, well, no, it's in the ventricle, because it's actually like way in the recess of the atrium, like the auricle, like very far away on the lateral, for example, or even on the VD. But usually when you're in the ventricle, the catheter takes a very sharp turn ventrally on the lateral radiograph, which you don't always see when it's in the atrium. And we've had those debates sometime where we would have to go to just do an echo and prove that the tip is actually in the atrium because they don't
Yeah.
believe. The other thing too is usually if you're really down the ventricle, when you remove your caps, you tend to have a pulsatile flow in your line, which is kind of like unusual. Um, but yeah, I've had a few like that where the radiologist called it like in the ventricle and it was not, just because it was in the really far deep down in the atrium, and sometimes the tip of that catheter can seem very ventral, very lateral on the lateral and the VD respectively. Um, so yeah, it's always kind of a no, not everyone agrees on where the tip of the catheter is on X-rays.
Yeah, for sure.
And to your point about the pulse style flow there, Cedric, JD has that really cool video of them showing the different pressures and the different pulse types of flows. Kind of like, for, criticalists or anybody else on here, floating a PA cath. You get pretty, I think, standard, both pulse style waves as well as pressures if you hook up a manometer to it as well. Just
Do you
like,
think we would still get that much pulsatile with how clotted it's been?
I mean, if it's in the ventricle and it's pushing up your catheter.
Yeah, must be. Ah, probably, yeah, I'm not sure. It does look scary on the X-ray. It's probably not.
And question mark for you too, Brooke, here, the insulin screening tumor or perineoplastic process in the background there. Did she come in hypoglycemic? Was that part of her, certainly the degree of uremia could be of contributing to her neurologic signs, but had she been chronically hypoglycemic as well? And was there any discussion of that being part of her neurologic problem, seizures and such?
No, she did not come in hypoglycemic. Uh, trying to look and see. She didn't. That wasn't like an initial issue.
Okay. Another interesting layer there. And
Yeah. Yeah, that actually took a good, maybe took 20, more than 24 hours. What do we have? So 13. She
would you?
came in on oh, yeah, about 24 hours.
Okay. Would you mind taking us through kind of your prescription approach or your approach on that first treatment, just in terms of, you said her BUN was greater than 350 or pushing those numbers and how to
Yeah.
approach that in terms of, clearance prescribed and your, duration of treatment and the rest of those elements.
Yes. Let me take a peek here.
And how much does she weigh?
She is 7 kgs. Where is my procedure part? Sorry, I'm not good at this.
Oh, you're doing great.
Where did my procedures go? Let's see. I okay. Fourth session.
As you're looking at that, I mean, everything, back on the, catheter placement, procedure and the sedation for that. Um, I mean, you guys, shifting some of the potassium and trying to address some of the acid base and volume derangements if there were any at that time. I mean, there's sometimes only so much that we can do until we get them on, and we know so much of that is if we can be efficient and quick with getting that catheter in. If they're really affected, I like to get my E-tube in there, right off the bat as well. Um, but sometimes I've had to forego that for a couple of days or get to the, another safe time just so that I can get them on the circuit and start addressing some of the acid-base arrangements. Although I guess, it depends how quick and efficient you are getting an E-tube in there as well. Some folks are a lot faster than others for sure.
Yeah, yeah, definitely. They were just worried about that swelling. I'm one of those people who always fights for it because sure enough, every single time I swear, by the time they're stable enough for an E-tube, then everybody says, well, we don't want to sedate or anesthetize them because they're doing well now. So I
Yeah.
always fight for them to I'm like, just do it. Just pop it in.
Yeah, and
Yeah,
that's it. If you can pop it in, great. If it's going to delay getting
Oh,
it
of
on
course. Yeah.
the circuit to actually start fixing some of the physiology derangements, then it's
Yeah, they're very quick at it.
yeah, yeah.
Yeah,
Um,
it's been kind of rule in San Diego that like every dialysis patient gets an E-tube, and usually we place it right at the same time like as the catheter. 'Cause just like you said, like once you start with the first dialysis treatment and they start to be better, nobody wants to put them under anesthesia again. And without an E-tube, those cases are kind of a nightmare to manage. So I would definitely advocate for an E-tube right out the gate.
yeah, and oddly enough, this dog is eating some now, which is very weird. Okay, I'm finding this thing.
Can I just ask a
Oh,
question about the E-tube that everybody places that has been routine for us as well? But I'm curious if it's the pen problem. We've had a fair number of patients develop E2 bleeding at the first treatment, enough so that they've required transfusions. Caveat being, I am not the one placing them, our internal medicine team does it. And these would be heparin-based treatments when we see it. I'm just curious if anyone else has experienced that. By Cedric's face, it feels like no, it's a pen problem.
No,
We've had a
well,
few. And so I've kind of reevaluated our strategy a bit to maybe
yeah.
delay in some cases or do a citrate-based treatment, their first treatment.
I feel like it's also like a technique problem more so than anything else. I've seen people placing E-tube and making really like bigger incisions than I would, and even like making an incision on the esophageal mucosa and serosa and things like that. I usually just do like a really small nick in the skin with my blade, and then I push my clamp through. And doing that, I think you're probably like separating tissue more so than incising it. And you get less bleeding. I would say like a little bit like when you do a perineal approach with cystoscopy, like you're doing like a very minimal incision and everything else is just dilation. And you don't get the same post-op problems. So, I mean, usually when I get bleeding, it's more so on the catheter side than the E-tube side, actually. Uh, but again, I mean, it depends like how you place them. And I've noticed in the patient that we manage, like depending if who's placing it, if it's internal medicine, surgery, or us, um, the way to place the E-tube might be fairly different. And I suspect that in some cases that might be the reason why you see some bleedings.
Yeah, I mean, we are a training institution, so I'm always curious whether that contributed to it, but interesting.
I agree. Like we actually only had one case so far that almost bled out after an E-tube placement. Um, and it had to have a transfusion and all this stuff, but and I can't I can't remember who placed it or what service did, but it was whoever didn't normally do it because the patient just happened to be over in that area of the hospital. It needed some other diagnostics, and it was people they didn't normally do it, and I don't know if it was a resident or an intern or anything, but yeah, that was we were like, okay, we just won't be doing that again. Um, but yeah, it's always, I mean, for us, it's always the criticalist or the nephrologists who are internal medicine doctors. Um, if they're having difficulty, then we find another internist and never had an issue with that. Um, but yeah, that's just one case, and we're like, oh my gosh, and they nicked something
Yeah.
for sure.
But there's a little vessel around there that you might nick from time to time, but if not, I mean, I haven't experienced major bleedings on my E-tubes so far.
Yeah, only one for us. I have the prescription here. We of course targeted a 50% URR, and we pretty much got that on the exact almost. We had a 6.5 hour treatment. At the time on presentation, um, eh, of course the dog, they initially tried fluids, and then they also, once they realized she was anuric, were trying mannitol and Lasix and things like that. But I have to say she looked like it to me too. We designated her on incoming as euhydrated, and there was not any peripheral edema or anything. And um, there might have been some scant pleural fluid, but um, nothing like that. So yeah, our KT over V was estimated at 0.7. We we had her on the Prisma in VVHDF, but we ended up not using any replacement fluid, and so no ultrafiltration, and we didn't use any replacement fluid. It was strictly dialysate.
And so I think I heard you say you got about a 50% URR over how many hours did you say?
6.5 hours.
And the pre-treatment BUN was 350?
It I 354 it was.
It's
That's actually, yeah, fairly aggressive.
Yeah. It's our post BUN was 150. Our pre-creatinine was 12.5, and our post was 4.9.
And what were the blood flow and dialysis flow used?
Um, we had it looks like we gradually ramped it up through the treatment. QD 300 mil an hour, hour 1, hour 2 is 350. Hours 3 to 5 it was 400. Hour 5 it was 500, and hour 6 it was at 600.
Yeah, I was gonna, I mean, I'll share kind of Cedric's. I mean, we should probably talk about dialysis disequilibrium risk in this dog because certainly, being the size that she is and the high degree of azotemia that we're talking about, I think that aggressive reduction in the intravascular space of urea and maybe some of the other solutes that we don't always measure certainly sets her up as one of those patients where I'd be really attentive and really worried about that. So much so I would probably in my hands I like the 50%. It gets us a big good treatment target. I would be more inclined to do that over 10 plus hours, just looking at the guidelines and the consensus statement and just knowing how big of a risk she is and along with the already neurologic signs and the seizures that she's having.
Yeah, I'm kind of wondering if timing played a part by, the doctor performing it was here at 7 a.m. and we were starting this treatment at like 6 p.m. and she had to stay.
Yeah, no, those are always practical, elements to how we functionally get some of these treatments done sometimes and what kind of benefit
Yeah,
they have for sure. I've felt that pain as
we and the tech too, even afterwards, thank God I wouldn't have made it. Somebody who did an early shift went home for 2 hours and slept and then came back and stayed all night with her. But the doctor didn't get that option,
Yeah.
especially having to work the next day again with appointments. So I mean, I'm not like trying to make an excuse. I'm just like, I bet
No,
that
no, but
probably
that,
played a
that
part.
that's always the difference between just like theory and reality, right? You gotta
Yeah.
you gotta make it with staffing issues and scheduling issues. And I've been in that position sometime where it's just like, well, what are we doing? Are we doing like a 50% reduction over like 10 hours, or are we just doing like a 30, 35 in 6, 7 hours and just go back at it tomorrow morning, with everybody just like getting some rest in the meantime? Or sometimes like the treatment goes well after like 5, 6 hours, you're like, you know what? Let's just treat overnight and do like a 12 to 14 hour, and then we'll be in a better shape tomorrow morning and the patient will just be better. Um, I feel like I'm more than happy to discuss how much URR we're gonna get on that first treatment, like the overall URR. I'm less inclined to negotiate on the rate though. Like I'd rather like say, okay, if we can only treat 6 hours, we're gonna shoot for like 30%. And
Mhm.
then we'll get back the dog to the ward and we'll start again tomorrow morning fresh, when we get some rest rather than like trying to get that 50% and cram it in 6 hours and get some risk of disequilibrium, especially when the dog is already neurologic and where potentially you may not be able to detect that you're getting some signs of disequilibrium.
Yeah.
So, I mean, I've been more aggressive than guidelines every so often, but I feel like as a general recommendation, as as often as possible, I try to stick to the guidelines, especially in our context, we're like a training facility as well.
Yeah.
Yeah, again, Brooke, Cedric and I think both gave the caveats. Not being in your shoes and your clinician's shoes. There's always decisions made in the heat of the moment with what's available to you. So this is
Sure.
more fodder for discussion around DDS and our general approaches as opposed to being any kind of critique of how you guys went about it. And that's
Yeah.
this is actually great. I love it when we've got different approaches for things because that spins up some really good discussion.
Sure. Yeah, honestly, to be honest, that's the first time I really looked at the prescription specifically. I was just so overjoyed how that I'm like, hey, we fixed it. Went from
And that
recumbent
and that's
seizures
also
to
the
wagging its tail
temptation.
the next day.
Yeah, that's also the temptation. Like when the patient is so bad, you say, well, you feel the need to do more. Maybe you're just like,
Yeah.
well, if we do just 30%, we're barely gonna make a dent. And that's why actually the recommendation, the guidelines is to do at least 35%, because the risk if you do less than that, if you do only like a 25 or 30%, is that by the next day, your patient will have rebounded at 350 again, and you're not going to be in a better situation. So that's why you need to find the fine line between treating enough so that you actually have a lower starting point before your next treatment. And if you want to treat more, then take the time to do it, not to put the patient's safety in jeopardy.
Yeah, I would say our nephro here is very comfortable pushing lines.
Yeah, that may come from our training though.
Yeah, I think so. I think it does.
I think the real quick, these are some of my favorite slides here to share is just some of the reverse urea effect is one of the main. I think there's a handful of different potential reasons for DDS, but the reverse urea effect is always one that's fun to talk about, where urea transporters are actually downregulated in the cell membrane, and aquaporin channels appear to be upregulated in states of uremia. And so the movement of urea outside of, from inside to out back to the intravascular space once it's cleared by our kidney replacement therapy efforts is a lot slower in these cases, particularly early on when they've been uremic for a bit. Whereas the aquaporin channels are in high um, participation in water flowing into those cells following an osmotic gradient that isn't usually there because urea is not usually an effective osmol. It usually moves around enough for us. So it's a really cool discussion.
I wonder if it factored in at all I don't know for sure. I didn't really pick her brain on it, but I wonder if it factored in at all the fact that we knew it was so acute because it had been going
Yes.
in and out of the hospital so
Yeah,
often.
I think it's definitely something to take into consideration. The risk of dialysis disequilibrium is increasing the more the uremic state has been chronic and the smaller the patient. So, I mean, if it's really acute and like 48 hours before the renal values were normal, for example, you can probably be more aggressive than if it's a dog that has been in kidney injury for like a week and with a BUN over 100 for like a week or so. I mean, definitely, I feel like the more chronic the patient, the more cautious I am with dialysis disequilibrium.
Yeah.
So that was probably part of the reasoning as well.
Yeah. Oh,
Well,
I just realized I forgot to turn my camera on. Sorry. Oh well.
no, hey, this was great. Um, I think we're just about at the end of the hour here, so we should probably start making some of our announcements. Brooke, there's so many elements that we could dive into having good discussions on, and I think we brought in the contrast induced or associated nephropathy, as well as those discussions that we have around the E-tube placement. You brought in some of your different catheter locks, as background to discuss there. We talked about the rates of solute removal and risk of DDS and some of the chronic versus more acute uremic states that may change the approach on that, but definitely referred back to the guidelines, which suggest a conservative rate per hour of removal, but also balanced with our practical considerations. I mean, we're all people at the end of the day. We've got lives and we have to take care of ourselves too. And so some of those things have to be balanced to some degree. And as Cedric said, if you only do a 25% total URR and do it according to guidelines, safely 5% per hour, the next morning you might be right back where you started, and you're chasing that. So there's a lot of different considerations there, and nobody's got the right answer, but this is where these discussions are great to talk about. Speaking of those discussions, Cedric and I are both going to be at IVEX in Savannah, Georgia, in September, and we're hoping to cross paths with some of you guys and trying to create a little bit of content while we're there too. So reach out to us if you guys are going to be there. It'd be great to connect with you guys in person and to talk a little shop and to just kind of share some stories, successes and others.